Great. Thank you so much for joining us on the podcast. I really appreciate it.
Oh, sure. It's a pleasure to talk to you anytime, Rebecca.
Thank you. Thank you. All right. So before we dig in, let's talk about, just so everybody kind of has a baseline of what we're discussing, what actually is dental sleep medicine?
That's a great question, actually. And I got a little background for you because as part of Dental Sleep Practice magazine, where I'm the chief dental editor, I just interviewed a dentist who started the American Academy of Dental Sleep Medicine. It was called the Sleep Disorders Dental Society back then, 30 years ago this year.
Okay. Wow.
And so I was asking Dr. Rogers, I said, tell me about the term dental sleep medicine, kind of the same question you just asked me. And he said that he coined the term about 20 years ago to describe how dentists interact with physicians and how do we blend them together? Because we have dentistry and we have medicine in the specific field of sleep. And how it got started back then is the physicians were figuring out how to help people who were sleeping badly, and it turned out they were breathing badly when they were sleeping, and so they discovered the disease of obstructive sleep apnea, came up with some treatments, and dental medicine provided treatment for that at the same time that CPAPs provided treatment for that. So dentists were involved from the beginning of treating bad breathing at night for adults. It's all adults back then.
Right.
And so they said, well, how do we label ourselves? Because we're not just, at the time they were thinking not just dentistry. So they decided to call it dental sleep medicine. So it's really just trying to describe the intersection between what dentists can do with primarily mandibular advancement devices in adults and what physicians can do for the medical side of the disease.
Okay.
So now it's an imperfect term, but it's what we think about these days. What we thought about 30 years ago. Yeah.
So can dentists actually diagnose sleep apnea?
Not currently. No, what the disease of sleep apnea is a medically recognized problem. So the role that physicians have to diagnose is important because there's a lot of interactions with other medical problems that dentists aren't trained about at all. What dentists can diagnose is a mechanical problem with breathing. In other words, we can tell whether somebody snores, we can tell whether somebody's airway is closing, but the medical situation of obstructive sleep apnea is a medical diagnosis. We need physicians for that.
Okay. And typically a physician, you would recommend somebody to a physician or tell them, hey, this is what I see, and you would communicate with that physician somehow?
Yeah, the biggest problem we have in the world really is, and it's talking about United States and adults so far. We're going to talk about kids here in a little bit. I know we are.
Yep.
But,
we're
going to talk about adults for just a second because that kind of sets the stage. And for adults, what we have is that 25 years ago or so, when I was learning about all this stuff, they told me that 15% of the adults that have sleep apnea have actually been diagnosed. Today, in 2022, if you go to the best experts, they may grudgingly acknowledge that 20% of the people that should be diagnosed have actually been through a process. So we're not getting anywhere in getting adults diagnosed over these 25 years. So that's one of the problems we have, is that we only have a few physicians doing the diagnosis. So what dentists can do is we can make more people aware that they have a breathing problem and facilitate the diagnostic process. And that's changed a whole bunch in the last even couple of years. COVID has drawn a new set of rules up for diagnosing.
Really? How so?
Yeah, because the in-person visits have gone to be minimized. We learned when we were forced to do telehealth that in fact, telehealth works pretty good, especially for something that's more consultative like sleep medicine and able to be tested in remote facilities. In the early days, the only testing they had was in specialized rooms and hospitals. Nowadays, that's still done, but it's done less often because we have home ways of testing at home.
So you can get a sleep lab level quality at home in kind of a real life environment.
Not quite accurate statement.
Okay.
Home, real life environment, those two are true. Quality, sleep lab quality, not quite there
Not
yet.
quite there. Okay.
But it's getting there because the technology is getting better, faster, cheaper.
Okay.
Withings, a big company out of France that has a lot of technology, they've really jumped on the board for these remote monitoring devices. And they have a pad, in fact, that goes underneath a mattress that measures many of the same biosignals, kind of a new term for us all, biosignals.
Mm-hmm.
They measure the same biosignals that we get out of the quote official unquote home sleep apnea tests. And because it's all in the cloud, they just released a study that had 68,000 patients over 11.6 million sleep nights. Biggest bunch of data that's ever been gathered about sleep. And they found out that 20% of the sleep tests nights were incorrect. So back to your question, sleep lab quality at home, not quite, because we have devices that accurately measure the biosignals, but we have to think that 1 out of 5 of those nights of testing is probably inaccurate. And that means that if you go to your sleep physician, you're screened by your dentist.
Okay.
And okay, great. You know what? That snoring is a problem. So I'll go and get tested. And I get hold of a physician, a sleep physician, and the physician says, great, I'll send you a monitor. You strap it on, we'll learn how you do. And you get 1 night with that. What if that's 1 of the 5 nights?
What if that's your 5? Yeah.
Now we have the worst possible. We have a false negative because we have a patient who has complaints. I'm snoring, I'm not feeling well. A dentist who says, dude, you got to do something about this. The patient actually becomes one of the 20%, and they go and they seek a diagnosis. But the test is faulty. And so the test says, no, patients, you don't have a diagnosis. You don't have a disease. Well, now what's the answer? The sleep physician doesn't have any place to go because their test says no. The patient still says, okay, dentist, you told me I was in trouble. Now they said I'm not in trouble. So what am I supposed to do about this?
Right.
And so it's a conundrum that we haven't quite solved yet. But the solution is going to be the fact that we can do multiple nights testing now for low money and low trouble. And if that's the case, then we can accept that first night and go, oh, that doesn't line up so much with clinical. Let's try tonight. But it all comes down to money on that.
And insurances, are we at the point that insurances will pay for or supplement these tests at home?
Sometimes what the accepted protocol right now is that if the clinical symptoms don't line up with the home sleep test, then that qualifies the patient to go into that in-lab, very detailed study. But that costs thousands of dollars for that study. Right. And so the insurance companies, they don't pay for that. So what is going to happen, I think, is the insurance companies will say, okay, great, doctor, you feel free to have the patient do multiple nights at home so we can eliminate that 1 in 5 event. But that data is all brand new and the insurance companies have, they don't change quickly. Right. So most of the sleep physicians I work with here in the Seattle area do 1-night tests. And if they don't qualify that way, if it doesn't line up clinically, it doesn't make sense to them, then into the sleep lab, the patient is invited. But patients don't like those sleep tests.
Right.
And so it's just a problem. One physician around here does 3 nights all the time because he's aware of the details of this stuff. But I'm not sure how that's paid for because the insurance companies don't tend to like to pay extra.
Right. Understood. So when it comes to adults, I know that traditionally, and we've had another guest on that's spoken about this, the CPAP is the way to go. The outside, I don't know what you call that. Yeah, right. The equipment. Yeah. But I heard you speak about the TAP system. Right. So what exactly is the TAP system? Is that an alternative?
Sure. Well, we got to back up again.
Okay.
So when they discovered the problem of obstructive sleep apnea, what Dr. John Remmers came up with is, wow, these people's airway collapses behind their tongue.
Mm-hmm.
And so the treatment that he and Dr. Colin Sullivan came up with is, well, if we put a little bit of air pressure into the upper airway through the nose, then we can splint that airway open so it doesn't collapse when they breathe. Okay, great. That became CPAP.
The CPAP.
And the measurement that they used as the kind of the dragon to fight in sleep apnea is called the apnea-hypopnea index. They measure how many times does somebody stop breathing, how many times does their breathing get restricted, and they divide by a time factor, and they have an index. So that's our score system.
Okay.
If our goal is to fix the score down to normal, CPAP is the very best thing possible, because it fixes the AHI, the apnea-hypopnea index, the score. It fixes that.
Okay.
But the problem is it comes with a bunch of baggage. And so the patients don't like it. Of course, some patients do like it, but only about 30% of people, according to most studies, actually use the CPAP the way they're supposed to. So we have a treatment it's very effective when it's being used, but it's only being used 30% of the time correctly.
Mm-hmm.
But it's still labeled gold standard treatment. And I think that label has to go away, because it's not possible to call something gold standard. It's only used 30% of the time.
Makes
And
sense.
study after study nowadays is showing that the overall health impact of CPAP is lessened because of this lack of use.
Okay.
So back to the early 80s, and already by the early 80s, the dentists were saying, well, wait a minute, CPAP isn't being used very well. People don't like that. Back then, even bigger, noisier, more cumbersome devices.
Wow.
And so some very smart dentists, Tom Mead in Albuquerque, Keith Thornton in Dallas, several, Alan Lowe up in Vancouver, BC, and others were coming up with these ways of holding the airway open, just thinking about the 3D anatomy.
Mm-hmm.
Is we have a movable lower jaw. Our mandibles can jut forward. And soft tissues, like the base of the tongue, are attached to that movable bone. So if we move the bone forward, maybe we get the soft tissues out of the way and do the same thing the CPAP was trying to do. So oral appliances were developed to do that very thing. And the Thornton adjustable positioner, named after Keith Thornton, who invented it, called the TAP, was one of the earliest devices. And so the TAP system, I think, is great because of a couple things I'll tell you about in a second, but it's really just part of what is now 150 or so FDA cleared devices, all aimed to do the same thing, which is to keep the airway from collapsing while people sleep.
150 approved devices.
Somewhere in that range. I don't know the exact number, but it's in that it's close to that number now.
I had no idea.
Yeah. Because the thing is that holding the jaw forward is the thing, but there's a lot of invention associated with the way to do that. And that's the big contrast with CPAP, because although positive air pressure, PAP part of those things, it can be applied in several different ways, because there's CPAPs, there's BiPAPs, there's adaptive PAPs, there's all these kind of things. It's all positive air pressure. But oral appliances have all these different designs because they really were developed in the hands of creative dentist types.
Okay.
And so, or some engineers, but mostly dentists. And so what they said, well, wait, we could try this little wing or that screw or this kind of mechanism or this hook or whatever the case may be. And it's all aimed to hold the jaw forward in different and more, in their view, the most comfortable, the most effective, the easiest to the patients to adhere to. And the key to it right there is it effective for the problem? Does it fix the AHI score, but also other things? And will the patients accept it? Whereas CPAP has to be accepted by how does the mask fit? How quiet can we make the pump? Those kind of things. The oral appliances being customized by dentists who completely understand the anatomy and the function of that part of the body, the oral cavity and the head and neck. They can say, well, this wing would be more comfortable. this design would address this muscle issue. This way we can give people to adjust it will be something that they'll actually use. So they
Now,
put
would
more
the
thought
tap
into
stay in?
customization. Yeah.
Does the tap stay in? Is it an oral appliance you wear all the time, or is it just when you sleep?
Oh, you only need to support the airway during sleep.
Okay.
Yeah, while we're all awake, the muscles of our airway resist negative pressures of breathing. When you breathe in, you pull a negative pressure into your chest to fill your lungs. Well, so we have muscle function to keep that from collapsing in the daytime. Nighttime is when that muscle function goes away, and taps and others keep that from collapsing. So the tap has a benefit because it holds the jaw forward with a little connector in the front. So it's free moving side to side, but not forward and back. So the jaw can't fall backwards while somebody sleeps. And then the other thing the tap has going for it that I really like is that it comes with a removable silicone mouth shield. So it goes under your lips and makes you a nose breather. And nose breathing is the key to health.
Yes, it is.
Yeah, and we're going to that's going to transition us into talking about kids, because Dr. Thornton said, wait a minute, we emphasize nose breathing for kids all the time. So what about these adults and these appliances? How can we make sure that happens? They came up with a silicone cover in the tap system that makes you an obligate nose breather. And that turns out to have so many health benefits that now we're going for far more than just fixing the score of the AHI. We're actually helping improve physiology by making sure people breathe through their nose. Nice.
Yeah. So that transitions right into where we're going to go, which is talking about kids. Hey, look at that. kids and kids health, because we know that as adults, what we've heard, right? We've all heard what not sleeping can do to you,
right?
And all the health impacts, but we really haven't until recently talked about breathing and sleep and the way they correlate with children and their health, as they're growing, but then that's what's going to manifest and cause all these health implications as they get older. So when we're talking about kids and we're talking about, let's just start with sleep specifically, why is that so important for kids?
Well, you know what? The really interesting part about that, Rebecca, they don't really know. We don't know why. We don't know the function of sleep in great detail. There's been big volumes written. One of the best is by Matthew Walker.
Matthew Walker,
yeah. Why We Sleep.
Why We Sleep, yes.
But even that's about adults. And so the key about kids is it's so difficult to test. Sleep medicine came around because of adult problems, adults having troubles in hospitals, adults being observed by physicians. So the rules are written for measuring adults. The tools were developed to measure adults. And somewhere along the way, of course, pediatricians and physicians said, look, there's little kids out there that don't seem to be sleeping well either. And there's these behavioral troubles. And in my practice, like, for example, I have 55-year-olds in my practice that have chronic disease, chronic inflammatory related diseases like cardiovascular disease and diabetes. Where did that come from? It came from decades of struggling to breathe at nighttime. So if I have a 55-year-old in my practice, at one point they were 5.5-year-old.
Right.
And so could there have been a root cause of some of these adult problems in children? Well, it makes logical sense, but then you kind of try to go to medicine and science and think, how are we going to figure this out?
Right.
And the only good way to figure, the only incontrovertible way of doing this is to gather up a bunch of 5.5-year-olds, figure out whether they breathe badly at nighttime, put half of them into some kind of treatment to fix that, and leave the other half untreated, and then wait until they're 55 and see what happens. Well, there's many things wrong with that. You'll never be able to do that study, because once you diagnose a child, especially with a disease, they don't have they can't be the 55-year-old says, I'm not going to treat this. You can't ethically withhold treatment from them. So
Right.
we can't do randomized control trials.
Right.
All we can do is we can look at populations of kids who were treated and populations of kids whose families decided that treatment wasn't going to be possible for them for whatever reason that is.
Mhm.
And then look and see. So that makes matching populations a little difficult. Some of it's been done. Karen Bonnick has done a big study in a town in England that's now about 20 years old. So we have some pretty good data about what goes on, but what we don't have to rely upon is the fact that we can consider a child who doesn't breathe well to be less healthy than a child who does breathe well. That makes sense. We don't need science to tell us more than that.
Mhm.
So let's figure out why they don't breathe well. And if they don't breathe well from bad habits, like for some reason they've just developed a mouth breathing habit, maybe we can fix that.
Right.
The biggest thing that we can contribute as dentists to the health of the world is to identify not kids who don't sleep well, but kids who don't breathe well. Because when we think about doing a diagnosis in a child,
Mhm.
and we put them in a sleep lab like we do at 55-year-olds,
Right.
and we try and measure what's going wrong, all we're really doing there, Rebecca, is we're measuring a symptom. Because if they don't sleep well, it's because they don't breathe well.
Right.
So why would we treat the sleep problem? Let's treat the breathing problem. And so why wouldn't they breathe well? We have to think backwards on that one. And now we run into a big problem, because if they don't breathe well, it could be a habit, but it could also be an underdevelopment of what Dr. Kevin Boyd, somebody else you're going to have on your program, no doubt, because he's a world expert.
Yes. He's also on our board.
Yeah, all those things. Kevin's, we're so grateful in the world to have a Kevin Boyd.
Yes.
But he came up with a term called the craniofacial respiratory complex, CFRC. And I told Kevin, I said, I love that concept. I love the thought of a craniofacial respiratory complex as the thing that we have to think about. I don't love the term because it's hard to say.
It's very hard to say. It's very hard to say. But, can you briefly explain to people that don't know what that is?
Of course, yeah. So think I'll explain the term: craniofacial respiratory complex. So we have the cranium. That's the skull. That's where your brain is, and that's the base of things. That's what things grow from.
Right.
The facial portion is what we see from the front. It's your cheekbones. It's the support of your cheek and how far forward your nose is, how far forward your teeth are. Where does your chin go, and how wide is this? So it's the three-dimensional structure that's the face. Okay. Well, what's inside the face, of course, are things that dentists pay attention to, like teeth and bites and smiles. I'm sorry.
No problem.
Edit time.
I will. Yep, absolutely.
But also those same bones that support what we see as the face and the nose and the teeth supports the airway. So and we dentists and ENT doctors as well, but mostly dentists, are the specialty in medicine for how that face develops. We're the only part of medicine that can go into a 5.5-year-old, recognize that bone is not growing to support the airway properly, and do something about it. Now, we're not talking about syndromic kids that have a genetic problem where they just have a growth issue that's developed that's by their genes. We're talking about normal kids, the millions and millions of normal kids. And I don't mean normal as, anyway. So regular kids, there's a better word. All right. So if in a regular kid in a practice, in a dental practice, where the dentist is looking at the structure of things, cranium, we're not going to do much about cranium. We can do a lot about facial, and we can do a lot about respiratory, the way that the child is breathing. because we can measure that and we can look at it. We can ask about that and we can notice things.
Notice things such as like the jaw being too far back, or there's not enough room, or what kind of things do you notice?
Yeah, we can know. First off, is are they breathing through their nose or their mouth?
Mm.
You know, if a child is sitting in your dental chair or sitting out in your reception room or in your family and they're breathing through their mouth, that's wrong.
That's a sign. Yep.
Yeah, because when the mouth is open and therefore breathing through the mouth, there's several bad things that happen. Several bad things. One of them is the tongue can't be in the roof of the mouth, because if it is, you can't breathe through your mouth.
Right.
That means your tongue is in the floor of your mouth. Okay. Well, if your mouth is open, your chin down, mouth open, your cheeks now put a little bit of pressure on the width of the upper jaw, the maxilla. And because the tongue is in the floor of the mouth, it can't resist that pressure on the palate. So therefore, the maxilla is pinched narrow. And when the maxilla is pinched narrow, the palate is pushed upwards. It's pushed upwards into the nose. So now we have less room in the nose.
To breathe. And where should, because I know everybody's going to be doing this at home, where should your tongue be actually?
Your tongue should be in your palate all the time. You know, not when I'm talking, when I'm resting, my tongue should rest against my palate. And not just the tip of my tongue up there, you know, behind my front teeth, but my whole body of my tongue should rest against the whole body of my palate. And in a 5.5-year-old, when that happens, then that little bit of pressure from the tongue resists the pressure from the cheeks, and the maxilla grows wider. The palate looks like the top of the tongue. Top of the tongue's flat, big, broad space. A palate should look like that. It shouldn't be a narrow little canyon. And because when it is a narrow canyon, it's going upwards and upwards into the nose, and it takes the middle of the nose, the septum, and bends it over to one side. So we end up with a deviated septum. And then if you can't breathe well through that smaller space, the low pressure there makes the soft tissues of the nose, the turbinates and other things that are involved in the nose, it makes them bigger, which makes it even harder to breathe through your nose. So it's a complex. So the diagnosis isn't that these kids can't sleep well. The diagnosis is they're breathing badly through a small space. And we dentists can do that. We don't need a sleep study to tell if this child is mouth breathing. We don't need a sleep study to know where the tongue positioning is or whether the jaw structure is growing too narrow or back too far.
Right.
So we diagnose what we can diagnose, which is problems in this craniofacial respiratory complex. Now, the other cool part about this is we dentists can do something about the growth and development of the bones, but we mostly dentists and hygienists currently aren't trained in how to do anything about the tongue position or how the tongue functions or whether the swallow is correct. So we have our myofunctional therapy colleagues and our speech and language pathology colleagues to help us with training these little ones to function properly in this complex the dentist can do something about. And neither one of those strategies are available to sleep physicians.
Okay.
Yeah.
Okay. Yeah. And you mentioned something that I mean, I understand it now from working with the Children's Airway Foundation, but y'all aren't trained to look at airways and to function. I mean, to focus on airways.
Yeah.
That to me is just mind-boggling.
Well, we're trained. Currently, Rebecca, we're not trained enough to focus on airways. We're trained to focus on the part of the body that controls the airway. But like orthodontists, for example, our orthodontic colleagues are trained currently to see kids in now what Kevin Boyd calls geriatric ages, you know, like 7 and 9, and see what they're trained to see, which is a beautiful smile, a bite that looks good, that coordinates with the function of the jaw joints. Those are 3 great outcomes for an orthodontic process. Right. At whatever age it is. Good bite, nice smile, coordinated with the jaw.
Sure.
What we have to do, though, is we have to add in this airway focus. And that instruction in that is ad hoc at this point, because it's not part of hardly any dental schools. There's a little bit of work going on in some dental schools, but not enough.
Okay.
Not part of medicine at all.
Right.
And so groups like Children's Airway First Foundation and the American Academy of Physiologic Medicine and Dentistry, AAPMD, ASAP is a group of dentists who have developed a children's focused education program. I'm very proud of the American Dental Association for carrying on the Children's Airway Initiative that we started with Dr. Boyd and I and others, started in 2018. So we have a growing amount of focus in education of dentists after dental school to pay attention to this from an airway perspective, as a craniofacial respiratory complex, not just a good group of teeth.
Right. And I'll have links to everything that you just mentioned in our podcast. So, people can go check all of that out, which is awesome. One of the things that Dr. Boyd has mentioned, and I know you and I have talked about this before, as a mom, the first time I heard him say this, I about fell out of my chair and thought, I'm a horrible parent, because he talks about, these kids that are 11, 12, 13, we're taking out teeth and we're putting on retractive braces.
Yeah.
Which, I get it. I understand that. But now knowing what these signs and symptoms are of airway disorders, that's the part as a mom that just sent me tail spinning going, oh, wow, I missed it on one of my kids. Oh my gosh.
Right.
So parents that are at this crossroads, that are being told, this is where we are, this is what you need. What are some things they could look for to ensure this is the right solution for their child? Because sometimes it is. But then what are the repercussions if they have an undiagnosed airway?
Well, one message we'd like for all parents, families, all inclusive, let's just call it families, okay?
Yeah.
Because there's families of all kinds of descriptions, right?
Absolutely.
So what families should look at is how early in life can we detect any signs of problems? And one of the things that's really common is, let's call it a 5-year-old, 5.5, 6, 7-year-old.
Mm-hmm.
If the front teeth have a beautiful smile, they're all touching like we'd look for in adult teeth, there's no gaps between the teeth, that's a very scary smile. Because what it tells us is that the bone structure isn't big enough yet. So when a child gets to be teenager years, middle school, and they go to the orthodontist, and the orthodontist says, oh, we don't have enough room for all of these teeth. We're going to have to pull out teeth and pull some things back together so we can give you this beautiful smile.
Mm-hmm.
So dentists that are paying attention to airway think, oh, that's horrible. We should never take out teeth. That extraction is the evil part.
Mm-hmm.
Well, I agree that extraction is the bad thing to do. But the problem isn't the teeth. The problem's in the craniofacial respiratory complex. The problem's in the bone, in the structure, in the airway support.
Right.
And for that, we have to look earlier in life.
Okay.
So what do we do? What's the message? The message is, as early in life as possible, get a pediatric dentist or a family dentist who knows about these things to give an assessment for breathing and airway. And some orthodontists, more and more orthodontists are understanding this expansion of their oversight, and they're paying attention to airway as well. And that's what CAF is going to be. That's the message out there, isn't it?
Yes,
is to get more of these health professionals paying attention to these little kids early in life.
Mm-hmm.
And then we can intervene when we can still grow the bone very easily.
Yes.
Because when Kevin sees a little kid who at 5 or 4 or 3 that has a developing problem, they can put in a little tiny springy thing and that bone responds to that. They can have the kid trained on where to put their tongue when they swallow, and the bone responds to that. And so when they're in middle school, the orthodontist looks in there and goes, oh, the teeth are kind of twist it around a bit. Let's line them up right so we have a beautiful smile, but we don't have to worry about taking out teeth because there's plenty of bone there to hold all those roots. That's the goal we have. It's when they're in middle school, they get the aesthetic alignment and the bite coordination, all the good things, but they don't have to worry about the size of the space.
Right, because that would have already been taken care of.
Because it grew big enough. Yeah, that's
right.
Yeah.
And at what age, just because I want to hear you say it, because I was surprised about this. Again, as a mom, what age should, or, well, I'm going to use the word should you start taking a child to the dentist?
Well, before age 1. Yeah.
See, that blows my mind.
Yeah. Well, because it blows my mind too. I don't treat, as you know, I don't treat little kids.
Right.
You know, I've never treated little kids. My dental practice was an adult dental practice. I'm super passionate about treating little kids in other people's offices now because they can, and it's so important. So the pediatric dentists have all the behavioral training to start a child before age 1 on things that can be done age appropriate for that. Now, we're not going to put any little springy expanders in a 1-year-old. That's not going to happen.
Right.
But what we can pay attention to is, are they breathing through the mouth? Is there an allergy problem? Is there even a tongue position? Sharon Moore, another future guest of yours, is going to, she talked last night about a child that she's seeing who's a year and 9 months. And so before age 2 there, and this child has special needs, but all the things that Sharon was talking about she could do, we're listening to her talk, we're understanding she could do that on non-special needs children even before age 1, because there's amazing things that parents can do, in this case mostly moms, but can do for their 12-month or their 10-month-old to get them on the right track.
Right, such as, what are just a couple of them?
Yeah, here's an easy one. If a mom of a newborn or a few months old notices mouth breathing, there's cultures where the standard is just the mom reaches over, just holds the lips together.
Like it.
Yeah, you don't have to do anything fancy, just hold the lips together. Start a good habit of nose breathing. Of course, there's a bunch of things that can be learned about breastfeeding and tongue position of that and how to swallow, and is there a tissue that has to be removed, and several things about that are all detailed that you'll have on future programs here. So because even at nursing time, breastfeeding time, first 6 months, 8, however long that lasts, that starts the whole process of muscle training and bone development of the craniofacial respiratory complex.
Right.
So when a pediatric dentist gets involved, before age 1, when a family dentist gets involved, maybe at 3 or 4 or 5, then we can start to recognize these troubles as early in life as possible and intervene as early in life as possible.
Right, when they're still malleable and we can make a difference.
Yeah, because if the bone is all plastic during those years, it can be pushed around. And if we recognize deficiency in growth, well, isn't it better to aim that growth at the right
time?
Target?
Yeah, absolutely.
Because we can do it later on in teenage years and adult years. Like a really top quality orthodontist, Dr. Bachow in my town, can do surgical procedures and move the bones around in 60-year-olds. But isn't it better at 6,
Right. Agreed. And I know we touched on this briefly, but as far as, your concept and your ideal, how should, going forward in the best scenario, airway-centric dentists and pediatricians, how should they be collaborating and working together?
Sure. So a child typically goes to a pediatrician for some well child visits, but oftentimes they're in there because of complaint, a cold, allergies, it's not doing well. Well, if the child just isn't doing well, what would be the reason for that? And so if the pediatrician's eyes are opened for seeing mouth breathing, for seeing, bad habits that way, a tongue that doesn't seem to fit, quote, in the mouth.
Right.
Those are things that can be addressed early in life. But the pediatrician doesn't have to know how to do that. They're not trained in this either.
Right.
So they send them to the right pediatric dentist, who now is, and the pediatric dentist says, okay, on this team, I'm going to need some habit correcting. My dental assistant can help you with that. I have a speech and language pathologist with training in myofunctional therapy that can help you with that. I have a dental hygienist with training in myofunctional therapy that can help you with that. And by the way, this jaw structure is too narrow here and set back too far. And so for your child, parent, let's think about doing this little expander or this habit corrector. There's off the shelf habit correctors that these kids can use, where they just bite on this thing and it helps train the muscles. It helps to shape the bone, helps to train the tongue. All of these come with exercisers. So, and some real popular ones are Healthy Start and Mile Brace, U Control. There's several of these kind of things out there.
Okay.
That every dentist who gets trained on this by some of the organizations we talked about earlier can use some of these protocols to give families an easy solution. You know, it's not difficult for a child to accept that they have to, chew on this little thing for an hour a day while they're playing. Because if you make that a routine, the kid goes, yeah, I can do that.
Yeah, they just do it.
Yeah, they watch the videos, they play the games, they do all the cool things that are made for kids. And sure enough, they get themselves out of trouble. And they go to the pediatrician for the next one. And the pediatrician says, what happened to your child? They used to be listless. Now they're full of energy. Or even better, they used to be uncontrollable, full of energy, and now they're normal.
Right, which is something that I think is interesting, that hypoxic brain injury. So you'll see kids with lowering IQs, ADHD, kids are getting labeled with that. And it turns out it's an airway issue.
Right.
Not always, but a lot of times it is.
Yeah. Stephen Sheldon, Stephen Sheldon, a physician in Chicago, he's a DO sleep specialist up in Chicago at Lurie Children's. He's one of our, global heroes in this. He actually says he doesn't think ADHD exists. He thinks it's a brain response to other problems. And the other problem that's the primary one is breathing issues.
Is breathing, which is amazing.
Yeah. Now, so I'm not sure I can agree. I mean, I'm certainly not a diagnostician for ADHD, but some kids have so too many kids have benefited from the medications to say it doesn't exist, in my view. But I think the vast majority of those kids haven't been evaluated for breathing issues.
Right.
And so I think that no child should be put on a ADHD medication without being evaluated for breathing issues by a competent dentist or an orthodontist who's trained in the craniofacial respiratory complex.
I would agree with that.
Yeah.
So you've mentioned a couple of organizations, and I just want to give you a moment, an opportunity to speak about those.
Sure.
We've talked about the AAPMD and the ASAP. And then I see behind you, you've got your Collaboration Cures 2022. Yeah. So, share a little bit about that with people, about these organizations and your involvement and what they do.
Well, the American Dental Association, the group for dentists, passed a policy statement for airway issues a few years ago, 2017. So that got the ADA on board. And as those of us that have started to expand our practices into more and more airway, we've also come together in subgroups, and AAPMD, and now there's several of them, AOSH, American Academy of Oral Systemic Health, and some others, have realized that, wow, respiration and breathing patterns, they are the fundamental. We're trying to help people get healthy across the board. We can't do that if they don't breathe well.
Right.
So, being small groups of dentists that are passionate about a certain subject, we find each other and we then start to think, what can we learn from each other? And it turns out there's physicians and there's physical therapists and there's speech and language pathologists all on the same kind of thinking plane.
Mhm.
We come together once a year and we call it Collaboration Cures because it's putting everybody together to try and find a way out of this health problem that we have. And in 2022, it's going to be in September in Phoenix.
Mhm.
And it's filled with speech and language pathologists and physical therapists and physicians and dentists and functional medicine folks. And we're all coming together to learn from each other and to sit in a conference room and hear a great lecture, to go through a workshop, to have a mixer where we, sit down with our DO colleagues or our PTs that we've never talked to before and say, what can you do to help
Right.
me understand the craniofacial respiratory complex even better? And what can I do to help you? I mean, it's just
Mhm.
all of that. It's just a fantastic group. It's my favorite event of the year is to go to Collaboration College, Collaboration Cures.
Nice. And I believe, isn't that where, did you meet? No, that's not where you met Candy.
No,
You guys
I
met
met
her earlier in the
a
year.
different meeting and
Yeah.
myofunctional therapy group. Yeah.
Yeah, that was awesome.
But, it's just, and going to any of these
Mhm.
is empowering, because when you go to when dentists, and I can speak from a dentist standpoint, we go to a dental conference, there's so much going on. There's lectures about vast numbers of subjects. There's a giant exhibit hall. And finding a small group of people that are passionate about something that just really excites you is more difficult. You go to a smaller meeting, like a myofunctional meeting, and you run into a Candy Sparks and you realize, wow, look at the energy right here. That's attractive. So I want to find out more about that. And so I sit down with a Candy Sparks, I sit down with a Brad Gilden, the physical therapist, I sit down with a Sharon Moore, the SLP, and I learn what drives them. And they hear what drives me.
Right.
And we all work together, and it's really fun and energizing and changing.
It is
Because
changing.
you can go to a lot of conferences and you go away and you don't do anything different because you don't really
Right.
learn much.
Right.
You go to a focus group like Collaboration Cures, and man, you come away from there and you can't not change what you do.
Right. And it sparks this conversation and it pulls people together, and it creates these little subgroups become bigger groups, and we're becoming a bigger and bigger movement, so to speak. I'm not sure what the right term is, but this group, we're all working, going towards the same goal, all driving together.
And, people that are gathered together in small groups like this with this kind of passion, they don't have, what do we call it? Agendas that require them to hold back information.
Right.
Their agenda is to spread it out.
Right.
And so the kind of people that I think of as like, there's more pie than anybody can eat.
Mhm.
And so the more we talk about, the bigger the pie gets. And so there's no reason to hoard my piece of the pie.
Right.
I got plenty of pie. So let me tell you what I know, and you tell me what you know.
Right. And that makes us stronger too.
Right.
Right.
What's that old quote? If I have an apple and you have an apple and we exchange apples, we each have an apple. But if I have an idea and you have an idea, now we exchange those and we each have two ideas.
Right.
So multiply that across 800 people at Collaboration Cures,
Mhm.
And look what happens.
Right. It is definitely powerful. It
Right.
is. Well, I thank you so much for being on our podcast and for
Sure.
all the work you're doing. Thank you so much.
Well, it's such a pleasure. This is well, you might be able to tell I'm energetic about this.
Yes, you are. I know. I appreciate that.
Thank you. And thank you for you and the Children's Airway First Foundation. I think it's new. It's a year old. Congratulations on that.
Thank you.
And the work that you and Candy and Brad and the other advisory council are doing, all my heroes on the advisory council. This is going to be something that's going to be a game changer for our profession, and that changes the world. And that's what we're after, isn't it?
It is. It's absolutely what we're after.